Good evening. I'm Harold Holzer, and I have the privilege of serving as the Jonathan Fanton Director of Roosevelt House. And on behalf of Hunter College President Jennifer Rabb, I want to welcome you to a very special live public program. It's just one of a series of Zoom events designed to keep our Roosevelt House community together, even during a time of social isolation. And of course, we hope to provide guidance and perspective to inform our audiences and our city as we navigate two concurrent crises, one a crisis in health, the other a crisis of heart and values. As we know, so far, nearly 5,000 visitors have zoomed in to new and encore programs in the last few months. And we thank you all for your interest in our programs. We feel we have a new obligation now to answer the long suppressed yearnings of our Roosevelt House community and our city and country. For those who have not yet seen President Jennifer Rabb's statement issued a few days ago expressing concern and condolences over the horrific killing of George Floyd, I urge you to read them on our Hunter website. And please know that Roosevelt House will be in the vanguard this fall as we examine more rigorously than ever in the human rights and public policy areas the shortcomings that have allowed historic inequality to survive and even thrive after generations in which the promise of equal rights has gone unfulfilled. Meanwhile, thank you as well for your generous contributions that you have made over the past 3 months to help Roosevelt House through this period, help us remain focused on the issues that concern us. As you know, we continue to reach out to you from the home where Franklin Roosevelt began addressing the crushing economic distress of the early 1930s, and where Eleanor Roosevelt developed and first expressed her passionate commitment to universal human rights. June, as you know, is Pride Month, when we remember another community denied human rights for too long, the LGBTQ community. And this particular Pride Month gives us the opportunity to recall, in the midst of a pandemic, how that community, along with government and society in general, dealt with an earlier health plague, HIV/AIDS. What lessons should be learned as we face down COVID-19 and face the probability of a resurgence in the immediate or distant future? We're grateful to Charles Kaiser, acting director of the LGBTQ Center at Roosevelt House, for conceiving of this discussion and for bringing together such a stellar panel of experts and advocates. In introducing them, I'll spend much less time than they deserve so we can keep as much time as possible for their discussion and your questions, which I urge you to ask using the Q&A function at the bottom of your Zoom screens. Please join me in welcoming epidemiologist Dr. Wafa El-Sadr, the Matilda Krim Amfar Professor of Global Health at Columbia and a principal investigator of NIH-funded HIV prevention trials. We also welcome David France, a leading AIDS reporter and documentarian who was responsible for the award-winning film, How to Survive a Plague. Hunter's own Ruth Finkelstein will be here. She is the Rose Dobroff Executive Director of our Brookdale Center for Healthy Aging. Sarit Golub serves as Professor of Psychology at Hunter and Director of the Hunter Alliance for Research and Translation, HART, dedicated to translating research into service and advocacy practices. Manoj Pardasani is Acting Provost for Graduate and Professional Education at Hunter and a specialist in community-based services for older adults. And as Manoj leaves Hunter for a new career, I want to thank him for his friendship and his great collegiality in his relationship with Roosevelt House. Lynette Ford is Senior Vice President for Programs and Prevention Services at the Gay Men's Health Crisis. with 20 years of experience in clinical management of HIV/AIDS care and prevention. And as noted, the discussion will be led by Charles Kaiser, former New York Times reporter and author of The Gay Metropolis, along with a book about another tumultuous year in our history, 1968, about which, coincidentally, Mayor Pete Buttigieg tweeted is at the top of his current personal reading list. Before Charlie begins the conversation, I want to introduce a special guest representing the New York City Commission on Human Rights, which she chairs, and which so graciously agreed to co-host tonight's discussion. Commissioner Carmelyn Morales has served as chair for nearly 6 years, but has spent her entire career promoting diversity and inclusion and preventing and prosecuting discrimination and intolerance. At a moment of history in which stubborn inequities are being laid bare and openly challenged, we could not have a better or more inspiring leader in the city and a more inspiring and appropriate partner for tonight's event. So thank you again to our panelists and our audience for joining us on Zoom. Thank you, Charlie, for organizing this event. And please join me in welcoming for her greeting, Commissioner Carmen Morales.
Hi, good evening. I want to thank you so much, Harold, for that warm welcome. And I want to thank Roosevelt House for partnering with the Commission on Human Rights to put together today's program. I think no one right now can say how much they need to be connected to other people. There is a shortage of ways that we're sadly able to do that in this time of social distancing. So I think any sorts of programs like this that bring us together and also speak to the intersectionality of what we experience as as queer people, as people in New York City, as people grappling with anti-Black racism. Any of the programs that we can have that bring these issues together is much needed in New York City. So thank you very much for that. I was thinking very much about today's program, and I was thinking very much about the subject, the similarities of what people have been experiencing and what we've been seeing at the Commission on Human Rights now, and versus what had been experienced by New Yorkers and what had been seen by the Commission in the 1980s during the dawn of HIV/AIDS, and what the different kind of community responses are, what the different government responses are. It's something as a queer Asian American woman, it's been something that I've been actually thinking a lot about, and especially in the beginning of the pandemic, when we were seeing many of our Asian American communities in New York City targeted and scapegoated. The look back to the 1980s and to what was experienced by many of our queer communities is something that's been very front of mind. So I very much appreciate the fact that there's a program that kind of shines a light unapologetically on some of these juxtapositions. I want to first start by saying for people who are not familiar with this agency, the New York City Commission on Human Rights, we are the city agency that enforces all of New York City's anti-discrimination and anti-harassment protections. Anywhere you live, breathe, work, exist in New York City, our law protects you. And pretty much nationally, I would even say, just speaking to some peers globally, we are oftentimes considered to have one of the strongest human rights laws around. One of the reasons for that is just the sheer number of protections that we have at our agency or under our law. There are 26 categories of protection. They grow fairly frequently. In just the, a little under 6 years that I've been at the agency, the law has been substantively amended, I think at least 12 times. So you see that in New York City, there's a real desire to make sure that people who are vulnerable, who are feeling or experiencing discrimination of all sorts, that we are addressing the ways they are experiencing it, and that we're finding ways under the law to provide legal protections for them. We have many of the protections that people see in other jurisdictions, but then we also have explicit protections that are seen in some jurisdictions, not others. For instance, explicit protections against discrimination based on sexual orientation, explicit protections based on gender identity and gender expression. And then we have other protections under our law that may be kind of few and far between in other jurisdictions. We were the first jurisdiction, and now I think there's only 2, maybe 3 of us that enforces a ban on salary history information in employment. We have what's broadly considered to be the most robust ban the box provision, making it illegal in New York City to ask in most instances about any sort of criminal history prior to a conditional offer of employment. Then we have other provisions also that speak to other types of protections that unfortunately don't exist in other jurisdictions. You know, strongly, I think, and I think what really speaks to this moment is the need to have a voice in government that addresses what are the relevant human rights issues that people are experiencing in the moment. I think these days, and especially in the last 2 weeks, that's felt very strongly in the area of anti-Black racism, where we're seeing not only the ways in which government itself, including law enforcement, is the entity that is forcing an experience on vulnerable communities in the city and otherwise. And it is difficult from that government position then to find other spaces where people are speaking out against whatever those human rights abuses are. Here, you know, in the last few weeks, we've been experiencing that with kind of bedrock principles of First Amendment protesting, with bedrock First Amendment principles of protecting our media, with the ways in which we have seen kind of the increase in state violence against Black people and Black communities, and somewhat the dearth of ways in which other government entities have been able to speak out against some of those issues. I think here in New York City, because there is a history of other parts of government being able to react to and act against those types of state violence, we've been in a much better position to connect with some of the communities that have been targeted. Looking at the effect of the pandemic, I can tell you that, you know, in the first 3 months of the pandemic, what we saw was a stark increase in reports into the commission that had some relationship to the virus. Many of those reports into the agency involved claims of anti-Asian discrimination, anti-Asian harassment. Even prior to the shelter-in-place orders, we saw ways in which either Asian businesses were affected by this type of scapegoating, by ways in which individuals out in public transportation, out on the street, in their communities were affected by this type of discrimination and harassment. And in just, I think, a 3.5 month period, we saw that this, the reporting into the commission, we had about 300 or over 350 reports in of some sort of COVID-related discrimination or harassment, of which 133 of those claims included some form of anti-Asian discrimination or harassment. And if you compare that number to the same type of claims that were reported into the agency just a year prior, you know, the increase is pretty staggering. If you look at those types of claims reported into the agency in 2019, you see that there were only 11 such cases reported in. So you compare 11 to 133 and you see the real increase. When we had been talking to the public or the media about this, you know, it was interesting because there, I think, are still a lot of people who doubt that there is such a thing as anti-Asian racism or anti-Asian harassment. And so in many instances, we were allowing for the numbers, the reporting numbers to speak for themselves. People often ask, is this a surprise? Is it surprising that we're seeing this happening in the context of COVID-19? And the response is that, sadly, it's not surprising that this is a sad and yet reliable historical phenomenon that we see that in cases where there is some sort of crises, healthcare-related crises or pandemic, it is often the case that there is a form of scapegoating or there is a form of or villainization that happens with a particular group. And what we would often compare it back to was the case of the AIDS, HIV crisis in the 1980s, where folks were not speaking up and they were also scapegoating members of the queer community or in the queer community itself. At that time period, the commission mobilized to create in 1983 the HIV/AIDS unit, which at the time became the first kind of focused unit at the commission, where they looked to specifically, expedite issues of discrimination or harassment that were being lodged by, at the time, gay, lesbian, bisexual, and transgender New Yorkers. They looked to ways to kind of report on those incidents for purposes of documentation, because this also predated the actual protections in the law. And then they looked for ways that documentation could take real effect, which actually ended up in legislation that created protections against sexual orientation discrimination in 1986, and then eventually gender identity, gender expression being added in 2002.
Commissioner, thank you very much. We have 7 more people here. We need to move along. Thank you very much.
Okay, thank you.
Okay. Good evening. My name is Charles Kaiser. I have the honor of directing the LGBTQ Policy Center here at Roosevelt House for Hunter College. Thank you very much, Commissioner. This evening is the 2nd event we have co-sponsored with the New York City Commission on Human Rights, and as always, it has been a great pleasure to collaborate with Daryl Cochran, the director of your Manhattan Community Service Center. On behalf of Hunter College President Jennifer Rabb and Roosevelt House Director Harold Holzer, it is my great pleasure to welcome all of you who have logged on this evening to hear this extraordinary panel of experts. I was co-teaching a class on LGBTQ history and policy at Hunter this spring, and we were in the middle of a section on AIDS at the moment the COVID pandemic exploded. I was immediately struck by many of the similarities between them, particularly the disproportionate impact on the more marginalized parts of our society. On one half of my generation of gay men was wiped out by the AIDS epidemic. As one of those who survived by happenstance, as all of us who survived by happenstance, I felt it was my duty as a gay writer to bear witness to what we had all lived through. That was my first motivation for writing a history of gay life in America, and this is how I described my feelings when AIDS began. Quote, "If you are a sexually active gay man in America, being alive at the beginning of this epidemic feels like standing without a helmet at the front line of a shooting war. Friends are falling all around you, but no one even knows where the bullets are coming from. There are no weapons to defend yourself, no medicines for the wounded, and if you want to flee, when you start running, you won't know whether your own wounds are fatal or non-existent. 3 years into this war, the battlefield is just as lethal, but now it feels more like a huge tunnel filled with fire, strewn with bodies and booby traps. If you're still standing, one of the lucky ones, you keep running faster and faster, but you can never outpace the inferno. At the beginning, there was nothing but terror and mystery. I would submit that our feelings at the beginning of the current pandemic were not altogether different. The one constant, of course, during both catastrophes has been Dr. Fauci, who began his current job as director of the National Institute of Allergy and Infectious Diseases in the 3rd year of the AIDS epidemic. I saw on TV last night saying the current pandemic was even more baffling than AIDS, but I think you may be comparing COVID to where we are today with drugs that heal very effectively with AIDS and not with the way we all felt when it began in 1981. Of course, the big difference between the 2 epidemics is that we will no longer have Larry Kramer to guide us and harangue us and inspire us, but I do think that Larry chose this moment for a very particular purpose, to remind all of us that we need to be in the streets fighting for justice all the time. Now I'm going to ask our panel to speak briefly, each of you, and give us a little bit of an idea of what you think is similar to what happened back then and what's happening now.
Yes, and thank you very much, Charles, and thank you all for the opportunity. And I'm really honored to be here with such amazing co-panelists, colleagues, and friends. I think all of us were asked to speak for 3 minutes and to focus on one similarity and one difference between HIV and COVID-19. Clearly, when I think back over the past 4 decades or so of the HIV epidemic, the one similarity that immediately comes to mind is how these pandemics and epidemics always shine a light on the chasms that exist in societies. And we've seen that with HIV in terms of course, the most disproportionately affected populations. Initially, of course, and remains so amongst the sexual minorities, LGBTQ community, but also globally amongst other populations, including women and young women in sub-Saharan Africa, drug users in other parts of the world, particularly in Asia and other countries. And then, of course, in our country here, the disproportionate impact of HIV now on African Americans and Latinos. These are enduring issues that we've seen, and not just for HIV, but also for many, many other health threats. And whether it is in this country or anywhere around the world, HIV has certainly shown us the most and disproportionately affected the most vulnerable amongst us. I do think also that when I think of COVID-19, similarly, the similarity is that, again, this epidemic is also shining a light on the similarities and the vulnerabilities that exist in our society. We know in this country the severe attack rates or impact or case numbers amongst African Americans and Latinos in this country, as well as, of course, not only the numbers of cases, but also the severity of disease and mortality and death rates from COVID-19 are disproportionately impacting particularly African Americans in the United States. In addition, I think we need to also realize that this is similarly happening in other countries around the world. When you look at countries like Brazil or even in England, for example, even in those countries, there's this disproportionate impact on racial and ethnic minorities in those countries. I think in terms of differences, I think one key difference is, of course, the trajectory of this pandemic, COVID versus HIV. COVID was identified only a few months ago, and in just a few months now, we have 7 million cases around the world, and affecting more than 180 countries have been reporting cases. This contrasts with the HIV epidemic, which had a slower start, but nonetheless, of course, by this time, 4 decades later, millions and millions and tens of millions of people have been affected. I think similarly in the trajectory and the difference I note in the trajectory of the two epidemics, I also kind of am interested in just the rapidity of the response to COVID-19 versus HIV, the rapidity of moving of research and rapidly trying to identify treatments and rapidly trying to mobilize to find vaccines. And this contrasts, unfortunately, with the early years of the HIV epidemic, where, as we are all aware, it took a lot of battles, a lot of fighting, a lot of advocacy, particularly by gay men and their supporters, to try to move the research agenda forward. And it is possible that the difference is that everybody is ultimately susceptible to COVID-19, while unfortunately with HIV, there was a sense that this was somebody else's disease, that the majority community did not feel like they needed to invest in the research, the resources that were needed to find the treatments and to find the vaccines. Maybe I'll stop here. Thank you.
Thank you very much. Lynette, can you chime in? Lynette Ford, Senior Vice President, Programs and Prevention at GMHC, please give us your understanding of the similarities and the differences between the two epidemics.
Good evening, everyone. I want to say thank you to the organizers for scheduling this panel, and thank you to everyone who is in attendance. There are many lessons learned from the HIV pandemic that we can use to address the COVID-19 pandemic. And today I will talk about 3 key things I believe we must do to address this public health crisis. I will focus on stigma, health inequality, and social messaging. Who can forget the intense stigma those diagnosed with HIV and AIDS were subjected to and continue to be subjected to even today? HIV stigma was placed on many people. Remember the 4 H's? Haitians, hemophiliacs, homosexuals, and heroin users. Because of this stigma, many from these groups were targeted, shunned, and some even died as a result. The same stigma that was ascribed to the Asian population at the height of COVID-19. The President of the United States labeled COVID-19 as the Wuhan or Chinese virus, an invasion by an unknown enemy, creating an environment that stigmatized and in many cases brought violence to Chinese Americans. This created a fear that we also saw with HIV. Stigma characterizes people as abnormal or normal. Stigma leads to not only the ostracization and shunning by others, but this abnormality is internalized by those dealing with an illness. Who wants to have the monster, as HIV was called, or the Rona, as COVID is now called? We must combat COVID-related stigma as we did and continue to do with HIV by educating communities and changing social norms on the individual and community level. We must fight against the normalization of stigma and shaming. We know stigma is fluid and moves from one impacted group to another, and this inherently always leads to negative impacts for marginalized communities and magnifies and illuminates the health inequities they often face. While African Americans make up 13% of the population, they account for 24% of COVID-19 related deaths. African Americans and Latinx communities are twice as likely to die from COVID. Yes, minority populations are more than likely experiencing a higher rate of mortality because of pre-existing health conditions such as hypertension or diabetes, but why is that? It is because of health inequality, which brings me to my second point. Our community have food deserts. Healthy eating is more expensive. Nutrition is essential to preventing comorbidities, and this is just one example. So to address the disproportionate rates of COVID-19 infection in communities of color, we must address the health inequality. We must ensure people have access to services that lower their risk for all comorbidities. And we must ensure social messaging to marginalized and heavily impacted communities speak to them in their lives as well as their resistance. Let's look at a lesson from early social messaging campaigns with HIV. Remember the Abstain, Be Faithful, Use Condoms social marketing campaign? I would say that those did not work for a variety of reasons. Chief among them, they did not account for the gender power imbalance, which caused some women to not feel empowered enough to assert their own agency and to take control of their sexual and reproductive health. And this was especially true for women of color, so it's no surprise that currently African American and Latinx women are overrepresented when we look at HIV incidence and prevalence. So what is the messaging on COVID-19 prevention, and does it resonate with communities of color? The messaging is that we must practice social distancing and wash our hands. Well, for many, social distancing is not possible, especially for those living in public housing, intergenerational families who are living together in a 1 or 2 bedroom apartment, or those who are incarcerated. We are essentially asking people to do something that they may not be able to do, even if they wanted to. Obtaining simple things such as soap for hand washing is difficult as well, and may not be doable for some people for a variety of reasons. Lack of transportation is chief among them. And let's not forget about access to face coverings such as masks. In many non-minority communities, police were distributing masks in parks and other areas where people were obviously not social distancing. But in communities of color, they were arresting those that were not socially distancing, and they for damn sure were not passing out masks. In recent weeks, that has changed. But the damage is done and the message was sent. We are not worthy of receiving masks, accessing reliable and timely testing technologies, and receiving competent health care if diagnosed with COVID-19. I would be remiss if I did not acknowledge the role structural racism plays in communities of color with respect to HIV and COVID-19, in addition to many issues we as a community must confront and solve. While there are many lessons learned from the HIV pandemic that we can apply to combat COVID-19, one thing is for sure: if we do not make a concerted effort to develop and utilize interventions and public health strategies that are culturally competent, effective, wholly funded, and scalable, we will continue to see COVID-19 ravage our communities as HIV did in the early days of this pandemic. Let's be on the right side of history. We must get this right, because we don't have the luxury of a do-over when lives are at stake. Larry Kramer showed us how to combat HIV, and as it was in the early days of the pandemic, and it remains now, silence continues to equal death. Thank you.
Thank you very much, Lynette. That was terrific. Sarit Gala, Professor of Psychology at Hunter College and Director of the Hunter Alliance for Research and Translation. Please speak.
Okay, great.
Welcome.
So I'm super happy to be here with folks that I respect very highly. I'm going to dovetail a little bit on some of the things that both Lynette and Wafa mentioned. I just want to start by echoing that we can't have this conversation, right, without recognizing the ways in which the COVID crisis, like the HIV crisis, intersects with epidemics of systemic racism and injustice in our nation. And that each of these epidemics have activism and energy, in part because each was responding to a situation in which the federal government's response was woefully inadequate. And I would say that as a huge understatement. I'm going to start with the difference. One real difference that I hope we will see between the two epidemics stems from the observation that has been made by many that activism around HIV in part has made tremendous strides for white, gay, cisgender men, but at times has left out or left behind their non-white and or transgender siblings. And at some points has even silenced them directly. Many communities right now, especially Black and brown gay men, people of transgender experience in New York City, don't have the luxury of sort of the title of our panel, remembering the HIV crisis, because they're continuing to experience it right now. And so one difference that I am hopeful about between these two epidemics, although there can be no hope without constant vigilance in this fight, is that the resistance that is emerging in response to COVID will help us draw connections to broader resistance movements right now to center racial justice and equality. To echo what Lynette said as well, health equity in our fight. So with that in mind, then I'll talk about what I think is the biggest potential similarity between the two epidemics. And I think it's a cautionary tale to us. The biggest similarity, I think, has to do with the most important lesson that I think we can take from our experiences with HIV. And that is that every time a public health intervention was introduced, a new public health intervention was introduced, its implementation exacerbated rather than reduced health disparities. So I'm thinking about when HIV antibody testing became available, it was disproportionately accessed by white, wealthier individuals. Rollout of antiretroviral therapy, which transformed HIV from a fatal diagnosis to a chronic illness, was associated with actually a marked increase in relative death rates for people of color and those with less money. And our first effective prevention medication, PrEP, pre-exposure prophylaxis, has been disproportionately accessed by white, wealthy gay men, resulting in dramatic reductions in new diagnoses that have not been experienced in our city and in our country by communities of color. And so I think that this is a warning and a call to action to those of us with HIV experience We need to take proactive steps now because, as Wafa noted, this epidemic is moving super fast, to make sure that new interventions, new testing strategies, new prevention vaccines, new treatment are introduced in ways that actually reduce health disparities and center health equity as opposed to increasing those disparities. And I have a bunch of concrete ideas about how we can do this, but I will shut up for right now and allow the next person to talk.
Thank you, Suri. That's a terrific list of things that we did before that we should try to avoid this time. Manoj Padarzoni is Associate Provost for Graduate and Professional Education at Hunter and my partner in crime in many of the things that I do at the LGBTQ Center. Manoj, take it away, please.
Good evening, everyone. Thank you, Charles. Thank you, Harold, for inviting me on this panel, and thank you to all our fellow panelists. It's daunting how much experience and knowledge is on this panel. I'm a professional social worker by education, training, and practice, and so I wanted to speak to what I learned was the intersection between social work, HIV/AIDS, and now COVID, and how social work transformed itself and some of the lessons learned. And Charles, you'd asked us to speak to what some of the similarities are and some of the differences are. And I think many of us are going to say this, many of the similar things. The impact of stigma, you know, in the HIV/AIDS epidemic, it was gay men and bisexual men who were stigmatized and marginalized and discriminated against. And today we see that against Asians and Asian Americans and other folks. The fear, the paranoia about who's sick. You can't see the illness, so you don't know who's sick, who's not sick. Who do you mingle with? Who do you socialize with? Who is safe? Some of those discussions are still the same. You know, it's a different illness, but some of those very same conversations and arguments happen again, and people get treated unfairly and criminally in some cases. The other thing that COVID-19 reminds us is that we've come far in some ways, but health disparities still exist. And this pandemic has again sort of highlighted the socioeconomic and racial disparities that some of our panelists just spoke about, and how it disproportionately impacts members of minority communities, our African American and Black communities, our Latinx communities, our socioeconomically underprivileged communities as well, and the burden they bear. And so I think that's a similarity that we're seeing now. And we're seeing it in the world of HIV and AIDS. It hasn't changed. It started with, you know, gay, cisgender, white men, but today we see its disproportionate impact on African American, Black, Latinx men. The other thing that I think is similar is the calls to behavioral change. When we started talking about prevention and education in HIV and AIDS, I think we talked about prevention. We, of course, came to it at a crisis before we started talking about prevention, but the whole conversation around COVID-19 has been about prevention, and it's about behavioral change. It's about motivating people to engage in certain healthy behaviors, and automatically that causes tension, that causes resistance. We saw people lined up with guns in a state capitol in Michigan, not understanding the full scenario of how they are putting themselves and others at risk. So I think what social work learned and does well, and I think some of the other professional disciplines do well, but I think what really social work has done is really highlight the importance of education, educating communities, empowering communities, using outreach as an effective model to get the information out there. Not just professionals working out in the communities, but peer educators. And social workers tend to be so diverse in terms of ethnicity, socioeconomic backgrounds, that in many ways they mirror the communities that they work in. And so there's a way in there to have that trust, to have that reciprocal sort of communication and dialogue. And the other part is organizing. As Dr. Golub said, activism is necessary, critical, essential, as Lynette said that, Ms. Ford said that as well. And again, how do we organize communities that are already marginalized or oppressed or vulnerable, but how do we get them to organize? And how do we all as society organize to get the services and the resources that everybody needs on an equitable level. And I'll just end with this. The one thing I was thinking of what's different, of course, there are many things, but the one thing that we didn't have in the late 80s and 90s is the technology we have today, the impact of social media, of the internet. So it could be a tool in getting the message out and getting information and education and organizing. It could also work against us, but I think that's one significant difference. The timeline to get information out and to get people organized was much longer in those days than it is now. So I think that is something that we could look at as a potential tool to address this pandemic. I'll stop with that. So other folks.
Thank you very much. Thank you, Manoj. I especially like your point about behavior modification, and I think it's important for us to remember that at the beginning of the AIDS epidemic, when people like Larry Kramer told gay men that they needed to become less promiscuous if they wanted to save their lives, they were violently attacked by many members of the gay community for being anti-sex. And no one knows more about Larry Kramer on this panel than David France, the author and director of the award-winning How to Survive a Plague, who has a brand new movie coming to HBO on June 30th. Welcome to Chechnya, about the appalling discrimination against LGBTQ people there. And he told me today that he is in fact embarked on a new film about the current pandemic. So David, tell us what you see is the same and what is different.
Thank you, Charlie, for that introduction, and thank you to my fellow panelists for your remarks that are so on point and so instructive and so thought-provoking. I have spent, as you know, the last 30 or 35 years studying activism around HIV and its impact in the world of science and drugs development. And I see certainly the impact of the work that ACT UP and other organizations like TAG and organizations on the West Coast and internationally have had that are permanent impacts in the way that drugs are researched, that clinical trials are conducted, the way, in fact, that scientists take on this sense of urgency that we're seeing in this pandemic that they had to be cajoled into in the last pandemic. It's a lasting legacy that that kind of direct AIDS activism has given us. And there are places where we think, on first blush, that activism has been helpful in ways that are really essential today. This enormous speed in the research that's going on is really tremendous, and as Wafa said, has no parallel in the laconic and academic approach that was taken to the research around treatments for HIV. And it's worth pointing out, we still don't have a vaccine for HIV all these years later. We still don't have a cure for HIV all these years later. But what we've mounted, and we've seen mounted in the past 2.5 months, is the largest medical race in history. It's the moonshot. It's the Manhattan Project. It's every other massive endeavor rolled together and multiplied by 100. And billions of dollars have already been spent. Billions more have been committed. The U.S. government has basically promised the country's treasury to the fight to find a vaccine that will get us out of this. And that kind of speed is in part informed by the lessons that I think that these scientists learned back in those days. And it's important to point out that many of the people who are doing the work today were doing the work then, and they are transformed by what they learned in the AIDS plague years, in the AIDS research, from Tony Fauci on down, as you pointed out, Charlie, that that there are many of the same players. They have been schooled. They are woke on the subject of moral and ethical approaches to their work. and there's a belief that their work is going to produce something, some miracle in some rapid way that, that I want to point out as being a serious difference in what the lessons of AIDS taught us. ACT UP, when it first formed, was a kind of an oppositional group that was demanding access to drugs unfettered by regulation. You know, give us the drugs. Don't stop them. Don't study them. We have nothing to take. There's nothing. You know, we have a certain death prognosis, and you're spending 7 to 10 years investigating these therapeutics. We should have access to them right away. We should work to weaken the structures of the NIH to get ourselves access to those drugs. And after a while, even those same activists realized what a mistake that they had made. And that mistake had produced almost 15 years of drugs that were, whose efficacy was not well understood. And there was a reckoning within the movement to turn back to the FDA and say, we've made a mistake. We really need your rigor. We need to make sure that the drugs that reach the market are drugs that we know how to use and we know how they'll work. And they became real partners with the regulatory agencies. They still weren't willing to accept the 7 to 10 year process. They found ways to short circuit that process to get answers in quicker ways. And that's part of the genius, I think, of AIDS activism. And what we've seen in this pandemic is the undoing once more of the role of the FDA and the replacing of that role with these kind of political concerns and political pressures coming out of the White House, but not only there, coming out of Europe, coming out of China, coming out of the major research initiatives on vaccines that are now promising to move into distribution into people's bloodstreams, vaccines that may not be going through the same rigorous study. And it looks from the outside like it's a rushed operation. The US, in fact, is calling it warp speed. All of this has undermined the faith of the American people anyway in the vaccine. 50% in the poll from 2 weeks ago, 50% of Americans say that they're unlikely to take a vaccine when it comes out, even knowing that a vaccine is the likely route out of this this social, cultural, and economic lockdown that we've been experiencing. And that is a real difference, I think, from the legacy that the AIDS activists thought that they were putting in place. Something that was an unexpected, I think, impact of AIDS activism and the AIDS plague itself was that it jump-started the queer movement, the queer civil rights movement, in a way that was totally unanticipated, totally unexpected. In the middle of AIDS, when people were fighting for their lives, the advances of the relatively young LGBT movement were minimal, and AIDS and the activism around it turbocharged that movement. And in the years after that, in the 30 years since the effective...
I agree so strongly with that. And every so often I read somewhere the AIDS epidemic decimated the gay movement, the LGBT movement, and the opposite, as you are saying, is the truth.
It's pretty stunning. And I have been saying for some time that a lot of good came out of the AIDS plague. And it's...
Yes, I agree. It's hard to say, but I think it's necessary.
It's hard to say. And what I hope is a parallel, and what I'm really buoyed by, is the activism that we're seeing now that is coming out of the Black Lives Matter movement, that has that same sense of traction and that same...
And urgency.
Certainly the same urgency, but it's, you know, in the middle of the first few weeks and months of this pandemic, I was feeling adrift. I could not see a future. I couldn't see a future for America. I couldn't see a future for the world. And when this movement that took foot in response to George Floyd's brutal murder spread, it spread this sense of hope and transformation and introspection and it you know, it's not about reform anymore. It's about a
Revolution.
brand new reality, a brand new America, a brand new world.
It's both a terrifying moment and a very hopeful moment. I want to remind the audience that we're here to be interactive. Please use the Q&A function at the bottom of your screen. We're going to take questions from all of you very shortly. I want to welcome Ruth Finkelstein, the Rose Dubroff Executive Director of the Brookdale Center for Healthy Aging. Rose, can you join us?
I'll do my best to channel Rose, but I'm only Ruth. That's okay. I'm going to try not to repeat the things that others have said, but just to put a slightly different spin on a couple of them. The similarity that strikes me strongly is that we initially got distracted by this canard of risk groups, when in fact the risk was racism, is racism as intersecting with poverty. And it's interesting how we want it to be a defined group other than that, you know, it's being old or it's traveling or, you know, the 4-H's in the past. I'm looking at Wafa and remember fighting adamantly with her about risk groups. And she was right, of course, I was wrong. But I wanted to make that point about that critical similarity. The second point I want to make is that we're addressing what is a social, broadly societal, social phenomenon as if it were a health phenomenon because it is manifested biologically. And so in some ways, it's allowing us to focus and of course, we need to focus on the treatments and the vaccines and the medicines, but we're not going to solve the inequities and any of the distribution of those products unless we focus on the broader societal things. And I think those things were true in both cases. In talking about the differences, trying to talk about different differences, slightly different differences. The direct economic effect is different. And I think
not just different, unprecedented, unlike anything we've ever experienced.
Right. And I think that in this way, HIV/AIDS and COVID are different. And I think this is amplified by and in turn amplifies the inequity situation.
But I do think there's an upside to the economic dislocation. I think it's certainly a factor in the fact that we see more people out in the streets demonstrating at the same time than any other time in my lifetime.
Right. And that comes to the next point, which we don't know yet is difference or similarity. Is Black Lives Matter ACT UP? I don't know. I don't think we know yet. I think Black Lives Matter is Black Lives Matter. And I think it doesn't serve a panel of largely white people to try to draw that parallel.
Well, let's ask Lynette Ford if she thinks so there are similarities between Black Lives Matter and ACT UP. Lynette, are you there?
Absolutely. I would definitely say that there are some aspects of ACT UP that I think Black Lives Matters employs. I think the early founders of ACT UP really created a blueprint for effective activism, with not only effective activism, with the end goal being ultimately changing the status quo and changing the structure, as David talked about. And
Yes.
I think that is evident in a lot of the strategies that were used by ACT UP and our founder, Larry Kramer. And I am hopeful, and I believe that Black Lives Matter utilizes some of those social activism theories. I would agree with Ms. Finkelstein and Charles that the level of political activism and unity that we are seeing across all socioeconomic backgrounds is unprecedented, and it is a beautiful thing. And I think that is what is going to lead to ultimate change on all of these things that affect marginalized communities so negatively.
Yes, this could be a defining moment for America. Sarit, you had some concrete proposals you didn't get to that you wanted to share with us. Sarit Golub.
Sure. I'll say a couple of other things too. I think that, you know, responding a little bit to a couple of things that David raised, I think that the issue of pharma right now and safeguarding against the control of pharmaceutical companies is going to be something that we have to really be careful about. HIV medications in the US is big business. PrEP has become extraordinarily big business. And in HIV activism lately, I have seen increasing what I would call creeping influence of pharma on our conferences, on our research, and on our advocacy institutions. And I think that one of the reasons that the US is going at warp speed right now is because of the influence of pharma. And so
and let us not forget, America is the only developed country in the world where a drug company does not have to negotiate the price of the new drug, which I think is a national scandal.
Yeah. And I think that it does have I think that a lot of researchers are collaborating with pharma right now in ways that probably need to happen. And I think that there's arguments about putting pharma profits to good use. I might argue that it would be better to put policies in place that limit these profits in the first place. So I think that that to me is a big one. And I think that, so that's one. What'd you say?
I totally agree. That's a very important point. These are bad dudes, and they've got to be reined in.
So they're all men.
Yeah.
The other thing I think I would say is I think that we have to, our language keeps changing, right? And so we changed from sort of high risk to highly vulnerable. I might argue that perhaps we should start talking about most oppressed. And I think that it might be really important to bring any COVID interventions to our highest priority or our most oppressed communities rather than waiting for them to come and access centralized care. I think we need to move away from some narrative of medical mistrust and call it what it is, which is historical mistreatment by our medical institutions, and a real rational response to that. And I think that we need to make sure that we're developing clinical protocols that remove unnecessary barriers to care. I think that one thing that we definitely learned from HIV is that we put up all of these barriers to accessing testing, to accessing treatment, and they had the intended effect. They reduced the number of people who were able to navigate those systems and get care. So I'll stop again. Those are my four.
Thank you. Wafa, is this a hopeful moment or a terrifying moment? Are you more hopeful or are you more scared of where we go from here?
I am known to be a most optimistic person. So, and I'm optimistic because I'm hopeful that we can actually, as a community, as a country, can, I'm hopeful that we can come together and learn the lessons learned from HIV and not repeat the mistakes we made. I'm beginning to see at least some examples of approaches that, you know, are appropriate. I do think we need to bring the services to people. I think one thing I learned through ICAP's work globally and our work here in Harlem is that you really need to bring the services to people. And I'm beginning to see much more of an appreciation that, for example, we need to do strategic, that testing should be strategic and it should be done by people from the community, within the communities themselves, setting up testing sites in churches and community centers. I think there's also enormous effort to try to utilize community members to do the contact tracing and so on and so forth. So I'm hopeful that we are beginning to think more about how do we get over these inequities and that we really need to reach the people who need the service and then provide them with high quality services right where they can get it easily and not sit back and expect them to come to us. I think that's a very good sign. I also think that I'm hopeful that if we can as well try very hard, that the advances are going to be rapid. And as others have said, whether it be advances in the way you test or advances in how you test or advances in treatment or prevention, is to think very carefully about how do we, who should be at the front of the line. Who should get access to these first, and not, as always, leave it to the institution that has the most resources or the individual with the most resources, but think very carefully as a society who should be at the front of the line. And I think those conversations are beginning to happen now in many settings, and I hope that this forum and others will generate these kinds of discussions in terms of who should be up front, who should be at the front of the line to gain access to the best interventions.
Manoj, do you see reasons to be hopeful at this moment?
Yes, I do. Thanks for that question. I think that we have learned a lot. I know it feels like one step forward, two steps back with where we are now, but I think we did learn a lot thanks to the people out in the field, thanks to the people impacted and affected by HIV and AIDS and the advocates and the service providers and the researchers that are still out doing the work. We have evidence-based procedures and processes and interventions to do outreach, to do community education, to help motivate folks to engage in healthy behaviors. And also we understand the intersectionality of identities, of socioeconomic status, race, ethnicity, and all of that. And so I think that, yes, and I think that technology is a wonderful tool right now that can get to more people and deliver access. But it's still going to be a fight. Resources are still not equitable for all communities, for all folks, and we have to keep that fight going. But I think we learned how to be effective advocates for public policy. Ruth has done that a lot in her career, and she has models that work. You've done it too. And I think we have effective models of intervention. So I'm hopeful. I'm really optimistic that I think we can. I think the issue was we started late, not us per se, but we started late as a society to address it. But I think we can get ahead of it.
Lynette, does GMHC have a strategy to make sure that the less fortunate get access to the best care in the current pandemic?
Yes, I think one of the things that GMHC has done that we are especially proud of is under the direction of Kelsey Louis, the CEO, we understood that because of the state being on pause, there were going to be many things that our consumers needed, chief among them, meals. So what we did was we couldn't offer our congregate meals program. So what we did was we offered a pantry service on the go, where we actually have a cadre of a staff that actually deliver 14 meals to clients every month. And the 2 weeks where the meals do not, the 2 weeks where they do not have the pantry bags, we send them a food gift card to help them address food insecurity. We've also are conducting wellness calls on about 3,000 of our clients to help them stay connected, to mitigate social isolation. We are offering telehealth services specifically for mental health and substance use. It's with older adults as well, because we know isolation is a key factor for different stressors for older adults. So we're really, really proud of the work that we have done despite the city being on pause and despite us not working at our actual location. The work continues.
Thank you. David, you're making a movie about this pandemic. If you wanted a happy ending, what's the happiest ending you can imagine that might possibly be the outcome of where we are today? I think you're muted. I think you're muted, David.
Oh, yes, it took me a while.
Thank you.
But all right, so I think that through all of this, and we've seen this pandemic hammer the most marginalized members of our community, hammer Black and Brown Americans, hammer, and now it's beginning to really destroy the developing world. And I would hope that where it moves us to a place where we examine the structural barriers, the structural exclusion from healthcare, and get to a place finally where we recognize that healthcare is a right and that healthcare is something that we as a society, that we as human beings owe to each and every one of us. That we get to the place in America, especially because it's so bad here, but around the world, to know that to open up healthcare universally to everybody. That would be my happy ending.
Mac Barrett, our distinguished curator of public programming at Roosevelt House, who's responsible for all of these wonderful events. Do you have any questions from our audience?
Yes, I do, Charles. Let's see. We've got a few questions from the audience that I'll read to you now. Most of them are general rather than directed to individual panelists. Here's the first one. How can we as individuals in society combat 2 or more unfortunate epidemics at once? For instance, racism and those that are against the LGBTQ community.
Lynette, would you like to try that one? Lynette,
Absolutely. I just actually answered the question in the chat from my perspective, and I will say that I have a caveat that I don't identify as LGBTQ/GNCB, but I do think that the problem arises when we try to separate out the issues. I think these issues, homophobia, racism, xenophobia, the health inequities, anti-LGBT initiatives, I think all of these things all fall under isms and phobia. And I think we can do more together than we can divide it. And I think they're inextricably linked.
thank you.
Can I just add one thing?
Yes,
This is
please.
Wafa. I do think also, I always am afraid or fear that we always pay attention to the crisis of the day. And I do worry about, we still have an HIV epidemic that's raging in our midst and also around the world. And it's of great concern that with this shifting of attention and potential resources towards, of course, combating appropriately another pandemic, that we lose track of the one that we've had for the past 40 years. And certainly this could jeopardize a lot of progress that we've made thus far. So we need to be able to pay attention to more than one thing, and clearly some of the other syndemics and are critically important, but we do have these two and many more major public health threats happening at the same time.
Yeah, I would begin by reducing the Pentagon budget by 50% and redirecting that money towards health issues personally. Mac, do we have another question?
Yes, here's a question from Sal Matera, an observation followed by a question. The big difference between AIDS and COVID is there was a long time before people realized that sex was transmitting AIDS, whereas very quickly the world knew that COVID was coming. COVID got more attention since it affects all people, whereas AIDS was deprioritized because it was perceived as a gay problem. How much does the panel see the different reaction to AIDS and COVID due to advanced technology versus an indifference to AIDS due to who is being affected?
Manoj, would you like to take that?
I'll start, and hopefully my fellow panelists will jump in. I think that the issue of how HIV or AIDS was transmitted and what people understood. It was understood initially that it only got transmitted between gay men due to unprotected sex, or that was injection drug users, for example. And so it became like a stigmatized population or group. And the idea was, well, people are doing this that they shouldn't be doing, and that's why they're contracting HIV or AIDS. But I don't think immediately people knew that it was just, it took a while to understand that there are other ways of transmission. It took a while to understand that heterosexual people could transmit HIV and AIDS or be infected with it. So it took a while, and there was a lot of sort of, can you sweat on someone and transmit HIV and AIDS? So I think some of the similarities are still there where people don't clearly understand what's going on. So I think, yes, there is a difference. One was considered more stigmatized, but I still think that people who are infected, people who are being, punished or being singled out for being transmitters or not being, I think they face some of the same issues, I think. So I think there's similarities and there's differences. I think what changes this is how many more people are at risk and how you don't know what what should be done in order to address it on such a global level. But I think lessons are learned from both.
Yeah, the biggest difference to me is that we never, at least among gay people, we never felt we could not hug each other. This is the first time we've been in a situation when you're not even supposed to give a hug. Sarit, do you want to chime in on this one?
Sure. I think that I think prejudice breeds prejudice. And I think that a failure to recognize the ways in which not only have we allowed racism and other isms to exist, but many of us have personally benefited from them, is going to prevent us from moving forward. I think that we need to be really careful, sort of as Manoj said, to make sure, and I think Lynette mentioned this as well, to make sure that our education and our messaging around coronavirus is clear, it's consistent, it's careful, it uses people first language, it recognizes structural determinants of transmission, that it proactively fights racist, classist, xenophobic, transphobic language. I think that there is a real danger of moving very quickly from these ideas of health disparities to these ideas that those people are transmitting or are vectors of transmission, which I think is what we've seen in HIV. And I think it behooves us to be incredibly vigilant about those dangers.
Yes. Mac, do we have another one?
Yes. A question for all the panelists. Could you please speak to any lessons learned from HIV that are specific to pregnant women and children that should be kept in mind when planning and carrying out the COVID response?
Lynette, do we want to take that?
I would think, Charles, that I saw that question and I thought maybe one of the doctors could answer that, but I would definitely say that, as many of the panelists have discussed, we have to make sure that our messaging is reaching all populations and not forsaking some. So that's what I would say to that.
Wafa, do you want to?
Sure. I mean, I can add, I mean, I think one thing we certainly learned from HIV epidemic is that often the research was not done early on amongst pregnant women and children, and they were for the drug and new treatment was identified. The studies were only done in non-pregnant women or men, and often it was years later that the studies were done in pregnant women to determine whether they were safe to be used amongst pregnant women. And similarly amongst children, often the doses were extrapolated from studies in adults. And thankfully, actually due to advocacy by HIV advocates over many years, there's a lot more recognition of the importance of early on, as early as you can, to try to actually test new drugs, new vaccines in all the populations that need to receive them. But we still have to be vigilant, because the whole speed of development of vaccines now and drugs, often people just want to do it fast and do it in the easiest population, get the answer, and then forget about the other populations like pregnant women and children, who equally importantly need these same treatments and prevention methods. So I think that's something to be aware of and to keep pushing for very actively.
One more question, Mac.
Well, one more, Charles? There's a few here. I didn't realize.
Well, we'll have time for two more, and then I think people should the panel should have a chance to give us their farewell remarks. But go ahead.
This is a question from Maya Bram, and she would like to ask this of panelists who lived through the AIDS pandemic. How has the response to government inadequacy been different for each pandemic? I'll leave it there. She added a little bit to it, but I think that's the heart of the question.
David, do you want to start that one?
Well, of course, anything Trump is different from anything else. We've never seen such madness at the helm at such an important time, which is not to say that Reagan and Bush weren't mad. They were driven by a different ideology. They were driven by an ideology that was
the religious right was important in the Reagan administration too. First administration
rose up and brought us the Reagan administration.
Yeah,
the first exercise of national power, and that impacted so much about what that administration did about the epidemic.
Yeah,
this administration rose up on its own hubris, and it is responding in that hubris to this pandemic with the idea that the one goal that is embraced and measured is the success of this president in his re-election campaign. These really are not comparable in any way, except unfortunately, the outcome is similar. The outcome is unnecessary death, extended suffering in groups of people who are not recognized as essential or even whole by the electoral base that brought both of those administrations into power.
Yeah. Ruth, do you want to add something? I think you're muted.
I think you're right. I think the particular derision to science and to public health displayed by this administration is different in kind. I mean, Reagan and Bush were horrible, but it was rational as playing to their base. This is just nuts. But then it's become a political trope where the president, oh God, I didn't call him that. base came around to turn on science and public health. And I think this is sort of a special depth of hell that we didn't actually reach even then.
Yeah, well, rejecting science has become a fundamental principle of the Republican Party in all areas,
right?
Which is unfortunate. Okay, Mac, one more.
Here's one from Elizabeth Cooper. During the earlier years of the HIV/AIDS epidemic, I thought the world could not ignore its disproportionate harms in communities of color. I was young and I was wrong. Do you think things might be different this time? If so, how and why?
Lynette?
I mean, I am hopeful that things will be different, Elizabeth. From what we're seeing right now, I do not believe that to be the case. Hopefully, as we continue to engage in activism and peaceful protests to address all of the issues that communities of color are currently facing, ranging from housing inequity to you know, schooling and the ways that schooling and the educational system is different depending on your zip code, police brutality. I am hopeful that a change will come in November and that there will be real policy change that, you know, will even the playing field a little bit.
I'd like each of you to give us a final thought, hopefully in 1 minute, beginning with you, Sarit.
I'm gonna raise up a voice that was in the Q&A from Steve Karpiak, who noted that we haven't yet discussed ageism. Ageism as it relates both to the HIV epidemic and certainly to COVID. I think that many of us were horrified by the ways in which older adults were dismissed early on in this epidemic. And so I hope that that's something else that can be raised up by us as well.
Yes, this is way beyond the alleged death panels of the Obama administration, to say the least. Ruth, ageism is a subject you might address.
Thank you, Sarit, for opening that. I think that the demonstration of ageism in the dismissal, the just outright dismissal of 40% of the deaths that are in long-term care facilities and the still not concerted and adequate investment and response to changing that, and the sort of ignoring the fact that there's an intersection between age and race and living situation that affects, that is very strongly affects both risk of getting COVID and how sick you get. And I'm not as optimistic as some of my fellow panelists. I believe that some of the problems that have been revealed are actually worsening by some of the structure of the response.
Wafa, do you have a final thought?
Yes, I think maybe one thing, me as an optimist, a pragmatist, but an optimist, is I think that the appreciation of essential workers is interesting.
Yes.
And novel and new, and I think I'm hopeful that this means something more than just that in the context of this epidemic, is that people finally are recognizing the person who's driving the bus and the person who's the conductor on the subway and the person who's handing them the groceries, that these are individuals who are really heroes at a time when all of us who had the luxury, or some of us had the luxury to work virtually and not to be put
These
ourselves
are the
in.
people who are literally making life possible.
They're making life possible, and they're really. I hope that's enduring, and that it means more than just that. That it means that we will respect such individuals, will ensure that they have the security and the economic security and other resources to be able to thrive. So that's one thing that gives me optimism in terms of our society overall. And finally, I do think it's really critical. I mean, we've had many triumphs as well as many travails during the decades of the HIV epidemic. And I do hope that as a society, as a community, as scientists, as community advocates, is that we look at those very carefully and take the lessons to heart, and let's try not to make the same mistakes and fall into the same pitfalls, and not reinvent the wheel. We just have to be we have to be careful to learn from those who preceded us. Thank you.
Thank you. Lynette?
Yeah, I would just want to say thank you to everyone, fellow panelists, and for all of the comments in the chat. And as Dr. Galoob mentioned, I do want to give a shout out to Evelyn, who talked about trauma. And I think as we look at HIV and COVID and all of the societal ills that we're currently facing right now, we're a traumatized population. But I am hopeful that we will see a change. And as Sam Cooke said, I do believe a change is going to come similar to the Arab Spring.
I hope you're right. Manoj?
Thank you to all my fellow panelists and for some illuminating questions. I really like someone who brought up the issue of ageism, and that brought to mind another issue. And I think that somebody else asked, can you deal with racism and LGBT and health? And I think it's they're not mutually exclusive, right? So I think when we talk about dealing with identities and issues and inequities, we're talking about intersectionality of race, of ethnicity, of living situations, economic conditions, access to resources, access to healthcare, the inequities that sort of they're cumulative. And so that puts some people, makes them more vulnerable to risk and to infection and to death and to illness. So I think that we have to address it. And like Ruth said, it is complex. It's not easy to know where to start. But I think we have to recognize that there's cumulative disadvantages in society and cumulative inequities that just layer on. And I think if we address it in sort of an inclusive, direct way, as Dr. Golub Sarit said, I think we can make some headway there. It needs to be inclusive. It needs to be proactive. It needs to respect human rights. This is a human rights issue. It is not a health issue. It's not a health crisis. It's a human rights crisis that we're dealing with.
Mr. France, you get the last word.
I am really pleased that there's so much of this conversation that we're having today in the streets of New York and the streets of America, the streets around the world, are focused first on the priorities that we've given to the police force, the powers that we've given to the police force, the militarization of the police force, and the budget that we've taken away from so many important parts of our society that would have protected us in important ways from this pandemic and previous pandemics, and that we're having a conversation now out in the open about redirecting those funds to places where they're needed, and that maybe we can address the question that Wafa brought up earlier, that we still have a raging AIDS epidemic in the United States, still 16,000 deaths every year. And we've just accepted that as like a low-level noise in the background. We can, if we redirect our priorities, as people are now demanding, make a difference in all of those things. And I'm really hopeful that we'll get there.
I hope so too. I hope we can get some of those 100 million voters who did not vote last time to get to November to change America and change our priorities. I want to thank all of you for magnificent contributions this evening, and President Raab, Harold Holzer, the entire team at Roosevelt House, Mac Barrett, Daniel Felkin, Magda, who makes everything work perfectly always, and Daryl Cochran, my partner at the Human Rights Commission, who was so helpful in making tonight a success. Thank you all for coming. Thank you all for listening. And may we vote in November. Good night.
Have a good night. Bye-bye.